Hello, everyone. Thank you very much for joining us. We are still seeing people joining here. So as it is time now, let me first welcome you all to this IAS Educational Fund Virtual Symposium titled Science and Communities in the HIV Response in Southeast Asia, organized in partnership with the Institute of HIV Research and Innovation, or IHRI. My name is Nitya Panupak, and I'm the Executive Director of the Institute of HIV Research and Innovation, IHRI, which is based in Bangkok, Thailand. Thank you all for joining us today. Let me introduce all of you to a few housekeeping rules for this webinar. Please note that this virtual symposium has live captions available, so please keep in mind that they have been generated through AI. And please note that due to the number of attendees, all participants are currently muted. And we have planned for time after the presentations for a Q&A session. So please send any questions that you may have for our speakers, focusing on their presentation topics in the Q&A box at any time. If your question is for a specific speaker, please indicate their name. And you will notice that there's a thumbs up symbol when someone asks a question in the Q&A box. So if you are thinking of the same question, or you find this question important, please click on this thumbs up so that we can prioritize the questions to be answered. And the recording and slides of this session will be available in IAS Plus very soon. And in case you have any issues with Zoom, you can find additional guidance provided in the chat box, and please send us any Zoom-related questions that you may have in that chat box. And please feel free to use that chat box to introduce yourself. Let us know from which country you are connecting. We always love seeing some interactions in the chat. And before we move on, I would like to thank our donors, Gilead Sciences and With Healthcare. So let me tell everyone the objective of this virtual symposium, this IAS Educational Fund. This symposium is to share the latest scientific advance and knowledge on HIV with a focus on the Southeast Asia region. This virtual symposium will last 2 days, today and tomorrow. Today we will cover the HIV response in Southeast Asia, new guidelines on long-acting prevention technologies, and best practices of CAP-LA implementation, the first in our region in Cambodia. And we will end with a panel discussion on best practices and sustainability of community-led responses to strengthen HIV treatment and prevention in Southeast Asia. These are all topical agenda that we all have in common. So let us enjoy the virtual symposium for these 2 days. Now, let me introduce you to Nattapon Dittabanjong, who is an independent health activist from Thailand, to give some opening words. Nattapon, please.
Hello, every people. But okay, you cannot start your video. Oh, sorry. Okay. Okay. Hello, every people. I am Nattapon Nittabanjong. I am this to independent activist and youth living with HIV in Thailand. But today I want to talk about something that touch us all: the power of the human spirit, specifically the hope and the strength and the bright future for those who are living with HIV. For a long time, an HIV diagnosis was seen as a final chapter. It was made the fair with silence and with stigma. But today we stand in a new era, an era of incredible medical progress, where with treatment a person living with HIV can live a long, healthy, and fulfilling life. The greatest challenge now is not just fighting the virus in our bodies, but fighting the fear in our mind, and the prejudging in our community. And how do we fight this? We fight it with purpose. We fight it with goal. A goal is a powerful thing. It gives us a reason to wake up every morning, a reason to take our medications, a reason to keep moving forward. It don't have to be a goal to change the world. It can be the goal of seeing your children gathering, the goal of a learning of a new skill, starting a business, or simple building a loving partner and a support friends. And here is the beautiful truth. When a person living with HIV set a goal and still for it, then do more. They do more than just empower themselves. They become a big cause of hope. They show that families that that rely goes on, full of joy, then teach their courage that a person what is not defined by them health status, them demonstrate to society that understanding and compassion are far more powerful than ignorance and fear. Our goal as a community is to build a world where everyone, regardless to their HIV status, feel safe, support, and empower to change them dream. A society that we live together, not just in tolerance, but in celebration of each other's strengths. Okay, so let us all whether living with HIV or as a life, promise to live with purpose. Let's repair stigma and let's repair stigma with support, fair with facts, and silent with open conversation. Together we can create a future where everyone has the chance to live their life to the fullest. Thank you.
Thank you so much, Pangpon, for that very great opening remarks to remind us all that even though we have all these medical advances, we still need to fight stigma and fear to gain power, to gain courage for anyone with HIV to live a full life. Thank you so much. And now let me introduce our first speaker. Kincho Wintin, Advisor in Prevention and Treatment at UNAIDS Regional Support Team, Asia and the Pacific. Kincho will be presenting on the HIV response in Southeast Asia. Kincho, the floor is yours now.
Thank you very much, Dr. Nitya, and good afternoon, dear partners and community representatives, and also good morning and good evening to colleagues joining today's event from different time zones. Let me quickly pull up my slide. Can you see the slide okay? Okay, so Yes, so as Dr. Nitya mentioned, I'm Kincho Winton from the UNAIDS Regional Support Team for Asia and the Pacific, and I will try my very best to share an overview of the HIV response in Southeast Asia region in 7 minutes, which is quite challenging. This symposium comes at a pivotal moment, I would say, because it really allows us to reflect on both progress and persistent challenges. And these challenges also remind us to strategically allocate the resources, sustain our hard-earned achievements, and accelerate the response through innovation and targeted investment. So let us begin with the snapshot of the epidemic. As of 2024, as you can see in the table, there were an estimated 86,000 new HIV infections and 59,000 AIDS-related deaths in this region. Out of estimated 2.1 million living with HIV in 2024, 1.37 million are receiving treatment, so quite a gap still. And compared to 2010 baseline, you can see reduction in new HIV infections and the AIDS-related deaths among both adults and children, as indicated by the percent decline in the rightmost column. In the interest of time, I won't go into detail, and let me move on to the next. However, the regional picture masks the diverse epidemic in countries because you just see that everything is in decline as compared to 2010 baseline. But when we look at the percent change in both new HIV infections and AIDS-related deaths at the country level, progress has been uneven. The slide on the left is about the percent change in the new infections, and on the right is about the AIDS-related deaths. So as you can see from the green bars, some countries have been making significant strides, while others are seeing rising trends in new infections and AIDS-related deaths, as marked with the red bars. For example, for the new infections, Laos and Philippines are experiencing the rising new infections, and for the AIDS-related deaths, Laos, Philippines, and Indonesia. So this really underscores the need for continued and targeted efforts to control the epidemic. A similar pattern emerges in the treatment coverage, and the slide also tried to capture more granular data by adult male, adult female, and by children. Some countries show high coverage, and while others still lack significantly. For instance, if you look at the dotted green line, which is marked at the 50% coverage, you can see a number of bars represented by different countries, as well as the different populations, subpopulations by age groups, well below, still well below 50%. Women in general have better access to treatment than men, but alarmingly, children's treatment coverage is low across almost all countries, with the exception of Malaysia. So this variability calls for accelerated and equitable access to services, especially for key and the left behind populations. This is a little bit of a busy slide, as we would like to share as much information as we can on the financing landscape. In this slide, you can see how HIV programs in Southeast Asia are financed. On the left side of the slide, you can see the HIV expenditure by source of funding, and green indicates domestic funding and the yellow for the international. It is encouraging to see that many countries have increased domestic financing for the overall HIV response. But if we move to the slides on the right, that is about the HIV prevention and treatment spending by funding source. And you can see that particularly for HIV prevention, external funding still plays a significant role. And let me emphasize again, it is particularly for HIV prevention spending. And this is very critical right now when donor priorities shift This really creates the vulnerabilities, particularly in countries that are still heavily relying on the external contributions. So if we are serious about meeting 2030 targets, we must really scale up prevention and mobilize domestic resources to ensure sustainability. Before concluding, I would like to highlight the recommendations from the next Global AIDS strategy that was developed through the multiple consultation with the stakeholders. First, we need a response that is truly people-centered and right-based, one that anchors dignity, equity, and inclusion, especially for people living with HIV and key populations. Second, we should integrate services and getting the most out of every interaction and investment. And HIV must be meaningfully embedded within the universal health coverage, sexual and reproductive health, mental health, and harm reductions, etc. Third, community leadership must be fully integrated and resourced as well. Community should be empowered through inclusive governance, sustained funding, and the supportive legal and policy environments. Fourth, we must also scale up innovation and access, including long-acting PrEP, HIV self-testing, and digital tools to offer people with more options and to close the service gaps. Fifth, the sustainability planning, which is really required to ensure that policy and programmatic priorities are funded into the future. And we also need accelerated domestic resource mobilization that also includes strategy for leveraging the private sector. We also need a strategy to maintain critical external financing where possible. The sixth is the legal and policy reform that involves dismantling punitive laws and reducing stigma to enable inclusive and right-based services. And we believe that next strategy will guide governments, communities, civil society, donors, and other stakeholders through the next phase of the HIV response. Thank you very much for your attention. And as we move forward, UNAIDS remains committed to standing with communities and partners, amplifying voices and driving innovations. Thank you very much.
Thank you so much, Kinsho. That was a very concise yet comprehensive presentation, telling us where are the major gaps in our region, as well as how we are going to go from here. And let me now introduce our second presenter, Heather Marie Schmidt, HIV Prevention Program Advisor at UNAIDS Global Prevention Coalition Secretariat and WHO in Geneva. Heather Marie will be presenting on new science and guidelines on long-acting prevention technologies, one of the innovation mentioned in the recommendation for the next Global AIDS strategy. Heather Marie, the floor is yours now.
Thank you so much, Dr. Nitea, and good afternoon, everybody. I am so pleased to be here with all of you. So diving right into it, last year in 2024, there were 3.9 million people who used PrEP at least once. The majority of these used oral PrEP. And while this number is growing, it is still less than 20% of the global PrEP target for 2025 and has been largely concentrated in Eastern and Southern Africa. The situation in Asia Pacific is even more dire than this 20% global target, with only about 0.2 million people having used PrEP in 2024 in the region. So less than 5% of the 8.2 million person target. And this hasn't increased dramatically over the last few years, despite some really impressive gains in countries like Vietnam, the Philippines, Indonesia, and other countries. So with over 1.3 million new HIV acquisitions last year globally alone, the effective use of PrEP really needs to be accelerated. The HIV prevention pipeline is really encouraging. So we have a range of promising options on the horizon, including a dual prevention pill. So that's both a combined oral contraceptive with oral PrEP. There is a monthly oral PrEP that has just entered phase 3 trials. There is a longer lasting vaginal ring and other forms of injectable PrEP that are entering trials. However, today I will focus on long-acting injectable lenacapavir, which is the next HIV prevention option that has or is becoming available. So in July this year, long-acting injectable lenacapavir was recommended by WHO. It joins 3 other safe and effective WHO-recommended PrEP options. And so, well known to, I think, everybody on this call, oral PrEP, which of course is the most popular and accessible of the PrEP options to date, the dapivirine vaginal ring, and long-acting injectable cabotegravir or Cab-LA, which is a 2-monthly long-acting injectable. And before I go on too much, I want to take this opportunity to be very clear that WHO does not support one PrEP option over any other. So while my presentation today will focus on lenacapavir, we know that choice is really important. Different PrEP products work for different people at different points in their lives with different partners and in different situations. We have evidence from studies such as SEARCH, from other sources, and just from daily life that we know that it is incredibly important to offer choice, and that this can increase overall prevention coverage, it can increase uptake, effective use, satisfaction, and of course, the ultimate aim, increasing protection. So really, one of the key take-homes is that the best product is the one that someone will use and will use well. So just keep that in mind as we talk about lenacapavir. And back to lenacapavir. So lenacapavir was recommended by WHO that it should be offered as an additional prevention choice for people at risk of HIV as part of combination HIV prevention choices, or approaches rather. And one of the things that I will hopefully remember to keep emphasizing is that lenacapavir, and in fact all PrEP options, none of them is a silver bullet. None of them can work by themselves in isolation. So remembering that, let's talk about lenacapavir. What is it? It is a first-in-class HIV-1 capsid inhibitor, and it is administered subcutaneously, so under the skin, every 6 months. It does have a mandatory oral loading dose, and this is something that's different to cabotegravir, which is administered intramuscularly, so into the muscle, and does not have a mandatory, it doesn't have a loading dose, an oral loading dose. Lenacapavir has received US FDA approval for prevention, EU market authorization. This has happened in the last couple of months. And it is under consideration in additional places for regulatory approval. It's also being considered for WHO pre-qualification as we speak. There are 9 early adopter countries that are expected to begin programmatic LEN implementation early next year, supported through Global Fund, and we know that PEPFAR is also supporting lenacapavir. So before I go into the evidence about how lenacapavir, the recommendation was made, I want to quickly look at how LEN is given, or how it's taken. So as I mentioned, it's an injection, subcutaneous every 6 months. In fact, there are 2 injections that are given at the same time. Usually it's given in the stomach, though there are some other injection sites that can be done, but usually 1 injection either side of the stomach. And these are about 1.5 mils each. The injections are given every 26 weeks. There is also an oral loading dose, and this is mandatory. It must be taken. So 2 tablets of 300 milligrams each are taken after the injection on day 1, and 2 tablets on day 2. And this oral loading dose is incredibly important to provide protection within 3 to 24 hours after taking the first 2 pills. Without the oral loading dose, protection can take at least 3 or 4 weeks. So this is really important, as you can see. For people who return on time, there is no need to repeat the oral loading dose. So if people return within 26 weeks, there's a 2-week window either side of that, then people just continue with the injections. However, if a person on lenacapavir does return at more than 28 weeks after their last injection, len does need to be restarted. And the other thing that I want to point out with how lenacapavir is given is that an HIV test, of course, is required. And WHO made a new recommendation about the use of rapid diagnostic tests and the fact that they can be used for initiation, continuation, and discontinuation of long-acting PrEP. Unfortunately, at this time, we don't have sufficient evidence to support the use of HIV self-tests for long-acting PrEP, long-acting injectable PrEP, even though they can be used for oral PrEP or the DVR. So moving a little bit more quickly now, lenacapavir was assessed across a range of countries and populations, including adolescent girls and young women, men who have sex with men, and other gender-diverse individuals. And it demonstrated a high efficacy with only 2 breakthrough infections across both primary publications. It also demonstrated a very high safety and tolerability. The most common adverse event was injection site reactions, but those rarely caused somebody to actually discontinue, which is really good. There wasn't any difference in safety or efficacy for adolescents aged 16 to 17 years, which is reassuring, but there is some data does remain limited for some key populations, such as people who inject drugs, which is being explored in Purpose 4, which is in phase 3 at the moment. Pregnancy is another key concern for a lot of countries. And what I can emphasize here is that no WHO recommended PrEP product, including lenacapavir, needs to be discontinued. So they can be continued during pregnancy and breastfeeding. For lenacapavir specifically, there was no increase in adverse pregnancy or birth outcomes in the analysis to date, or the completed pregnancies to date, and there's no dosage adjustment required. So basically, when someone becomes pregnant, the choice to start, continue, or switch PrEP should be made by the individual following a discussion of risks and benefits, like for everything when somebody is pregnant, with a healthcare provider. So the evidence from the clinical trials does show that infections on lenacapavir, or breakthrough infections, are very rare. However, both of the breakthrough infections in Purpose 2 did show antimicrobial or antiretroviral drug resistance. However, because lenacapavir, as I mentioned before, is first in class, the current public health impact is limited, basically because it's not used widely for treatment. And this is a little bit different from cabotegravir, which is quite similar to dolutegravir. So the concerns about drug resistance are quite different. Mathematical modeling suggests that lenacapavir could substantially reduce new HIV infections if it's rolled out at large scale. And one of the key determinants of that is just increased coverage, that there are more people that are taking it. So in concentrated epidemics like the Philippines, for example, providing lenacapavir to, say, 58% of people at most risk, so 1.1 million people, could avert 45% of new HIV infections. So it's a lot of people on lenacapavir. It's a lot of potential impact, modeled impact, but of course, it still means that a robust HIV response and testing and treatment and other prevention is needed. Very quickly on values and preferences, we do have good evidence that lenacapavir is highly acceptable and even desired by many individuals and communities and providers. And one of the things that I really want to highlight here is an interim analysis of Purpose 1. So these are people who took lenacapavir, suggested that about 2/3 of participants may have preferred len. Just under 1/3 still preferred oral PrEP. So these are people who were on the trial for about a year. There is, however, across studies, including PrEP Appeal, which was done in Asia Pacific, a clear preference for less frequent dosing because of reduced user burden. And there have been a lot of concerns expressed across studies, including injection-related pain, side effects, scheduling challenges, costs, and things like that. But it is likely that lenacapavir is quite feasible. And we've seen that from cabotegravir implementation, as limited as it's been. So what are the implications for implementation? Well, one thing to really emphasize, and it is emphasized in the WHO recommendation, is that lenacapavir should and must be delivered as an additional prevention choice alongside other HIV PrEP and prevention options. Again, it should not be the only thing that's offered. It is not a, as we call it, silver bullet. There are some other things to consider. So population-specific needs, we know that the needs of adolescents and key populations, people who are pregnant and breastfeeding, there are specific things that they may require. And so we do need to make sure that services are equipped to meet the diverse needs of individuals. And within this region, many of you have championed really person-centered approaches to care. Differentiated service delivery is incredibly important. We have done amazing work in this region on differentiated service delivery options for PrEP, and Dr. Nitya, being the godmother of differentiated service delivery PrEP, really has made such a difference. And we don't want to see it go backwards. And there is a real danger of that with something that is injectable, with an injection of re-medicalizing this. However, there are already plans in places like Zambia to really use community health workers to administer the injection. So I think this is something that we need to be acutely aware of. Community engagement throughout introduction is, of course, crucial, and this includes planning all the way through to delivery and monitoring and evaluation. And it's not just about, demand generation, which is, of course, crucial. Integration into services, of course, again, lenacapavir should never be delivered alone. Awareness raising and demand generation activities. One of the things we've done very, very poorly across the world is creating real demand for PrEP. And this has been a little bit because of fears around that there isn't enough supply, that services couldn't handle it, that we might be promoting it to people who don't need it or the wrong people. I don't believe anybody who presents for PrEP is the wrong person. But there have been a lot of fears. And so I think we really need to take it forward and not be as afraid to promote PrEP and to particularly promote lenacapavir. There will need to be provider training. This is a different type of PrEP. Supporting persistence, effective use, and client recall. This is going to be incredibly important. I mentioned that very short window to recall somebody for an injection so that they don't have to restart. This is going to be a really important point for services and for individuals. And of course, monitoring and surveillance systems should incorporate adverse event monitoring for pregnancy and breastfeeding, seroconversions, and drug resistance. And emphasizing again that full community participation. And finally, the research gaps. There are some research gaps. Lenacapavir is incredibly new. Implementation science can provide answers to some of these, including, and I think one of the key things is about how product choice switching and persistent happens in the real world. How do people use lenacapavir and how do they use it within prevention? Those optimal service delivery approaches, how to best deliver it for many populations, the costs and the impact, drug resistance. But the key thing to remember here is that further research should not delay programmatic implementation in countries. And this is my final slide. I'm sorry, I know that I've gone slightly over. But lenacapavir offers enormous potential to increase HIV prevention coverage. It's acceptable, it's efficacious, it's safe, it's long-lasting, and likely to be quite fairly affordable to low and middle income countries. There's been recent announcements about $40 for the injection for a year. It's a great option for people who struggle with an oral pill, for whom oral PrEP isn't suitable or they just don't want it. For those wanting increased convenience or increased discretion, it will not fix access issues, and it could exacerbate them because of that short time to return for injections. It's not a silver bullet. And so it's really important that we leverage the successes and the lessons, the things that we haven't done well with oral PrEP and also CAB-LA. So we need to build that demand, support DSD, enable rapid and broad access, facilitate choice, and look at new opportunities for innovation. We shouldn't let implementation science delay the rollout, but there is momentum and support, and so there is an opportunity. So thank you to everybody involved in the guideline development. And also just a shameless plug to say that we're providing another webinar this afternoon about the provider training. Thank you.
Oh, thank you so much, Heather Marie. That was really, really great. And first time someone called me godmother of something. So thank you for that privilege. And yeah, I cannot agree more. And I have seen so many questions about Len, in which we will keep it for the Q&A session. So please feel free to add more questions to the Q&A box down below. And talking about implementation science, I think that's very, very important. And Asia Pacific, I think, is much behind the other region in terms of like being thought of potential sites for implementation or implementation science. So we need to send stronger, louder voices from the region. So thank you very much, Heather Marie. And that really brings us to our third speaker, Dr. Bora, Ngoc Bora, who is the Deputy Director of National Center for HIV/AIDS, Dermatology and STD from the Ministry of Health in Cambodia. Dr. Bora will be presenting on best practices of CAB-LA implementation in Cambodia. And I think that's the first and the only implementation of long-acting injectable PrEP in our region. So the floor is yours now, Dr. Bora.
Yeah, thank you, Mr. Chair, Dr. Nitya, and thank you for IS team for the opportunity for symposium. I would like to share my screen. Yeah, actually, for today, I will present about the implementing of HIV pre-exposure prophylaxis in Cambodia. And in this also, I prefer to share with you the Cambodia PrEP introduction and scaling up for so it. And maybe you see in the slide, the Cambodia introduced the oral PrEP in 2019. That health facility implementation start in July, and community-based drop-in center PrEP access begin in 2022, and oral PrEP we continue to scaling up, and up to 2025, the injectable PrEP that we call CAB-PrEP implemented begin in June 2025 in the 4 sites in the Phnom Penh city. And this year, and another 5 new sites will in the new province in early 2026. And this month, 25 too, we also introduced the DVO PrEP, Dapivirine PrEP implementation launched in October 2025, and 4 sites in Phnom Penh and in plan to scaling up in additional site in the Phnom Penh too. And this implementing, we follow the diagram here that talk about the walk-in patient or walk-in client come to hospital or come to CBO site or come to by virtual appointment somehow that need to counseling them for assess the PrEP. And for this slide, I want to share also about the evolution of the PrEP implementation in Cambodia. As you know, we start in 2019 for the oral PrEP. So in that time, the SOP, the oral PrEP SOP has approved from the MOA in May that we start from that time. And 2020, we established another 5 health facility PrEP site in Phnom Penh city and another province. It's part of Battambang, Timinjay, Siem Reap province. And until 2021, we have a CBO PrEP and drop-in center SOP endorsed to implement it. So we start CBO PrEP in 2022 for drop-in center CBO PrEP. And up to 2023, we have established 10 health facility and 9 CBO PrEP sites that conduct. And then we conduct a qualitative PrEP drop-in, drop-out survey. And we also conduct the qualitative CAP PrEP acceptability and feasibility assessment among the key population. And in 2024, we established the 4 CBO PrEP drop-in center, and we conduct the qualitative in feasibility and acceptability among the women at risk. And we also developed the SOP for Cambodia PrEP and Dapivirine PrEP in that time. And in this year, 2025, we start introduce the Cambodia PrEP and Dapivirine PrEP. That we have conducted CAP PrEP TOT training, and in this time oral PrEP also scaling up to 49 sites and 34 facility and 15 CBO PrEP. And we established more at 8 facility and 7 CBO. And CAP PrEP SOP approved in May, and we launched in June with 4 PrEP sites in capital city of Cambodia. And for DVO PrEP SOP also approved in the August, and we launched this month with 4 PrEP sites. In this, we also have planned to scaling up in 2026 for the oral PrEP established with another 34 facility and 6 CBO, and CAP PrEP also will introduce another 8 facility and 8 province, and DVO PrEP also established with the same Cambodia PrEP. And we also plan to introduce the tele PrEP and mobile PrEP in the Phnom Penh and another province. And of course, the lenacapavir SOP, and we are in plan to prepare on that drug supply and demand creation curriculum and tool in our plan. And 2027, we will establish the additional 34 facility site, continue for Cambodia PrEP and DVO PrEP implementation. And we hope that we can launch the lenacapavir PrEP implementation in that 2027. And we come back about the Cambodia PrEP part of launching. We have first step, we follow that by preparing, follow the recommendation from WHO. And we conduct the acceptability and study. And we developed the CAP-PROP SOP and also developed the training curriculum and procure the CAP injectable by using the Global Fund support, and MOA also endorsed that guidance. And phase 2, we phase the implementation on the strategy. We have 4 sites implemented, and phase 2 we will expand to 5 additional sites. And phase 3 we expand in high burden province in Cambodia. And for the priority, we prioritize to MSM, TG, and EW, and PIVOT, and target also CAMSEC participant. For the service delivery, we also integrate with the existing facility base for our product service and the client central design and friendly service provision. And for community engagement, we also integrate with the existing product service and community involvement at each step. And outreach are key promoter and emphasize on the product choice. And if we look back on the monitoring and coordination, we use the DAS tool for the real-time data tracking. And our indicator also include uptake and retention by product modality. And we also conduct like quarterly technical working group meeting by include the CBO team to join our discussion. And we introduce the national Telegram group chat for improve our retention. And this slide we prefer to share that where we are now. Yeah. Actually, you can see this data up to 2025. Since we start from 2022, we see that we have 49 product sites in Cambodia that have 15 CBO sites among these. So we have a client up to this the end of Q3 this year. We have 42,000 clients, 42,643 clients. And among these, we have most of those 69% MSM, and TG 13%, and female entertainment worker 50%. And if we look back on the CAP-PROP that Cambodia enrolled up to August 31, 2025, we can see that now we enroll 226 clients that include 95 new and 131 switching from the ORA-PROP. So if we count in the person, we can see that 70% of these are MSM, and 16 from the TG, and 24% female entertainment worker, and other is GP. So from this, we think that our Telegram channel group have create for all 49 product sites, and enable service to provide to provider and outreach worker to communicate with each other and share additional information regarding the service and answer the question. And we also have adapted ability in the challenging with active participate and advocate from the community. And we have at CBO drop-in center, ORA-PROP, CAP-PROP, or DBO-PROP, and real soon we will implement the tele-PROP and mobile PROP. And we have a routinely quarterly meeting with the provider and CBO and community lead monitoring forum that provide feedback and guidance for service improvement. So for the empowering community lead PrEP demand, we have like community lead PrEP ensuring those most affected are at the forefront of decision making and fostering and ownership and inclusivity. And we also engaging beyond observation, allow for genius leadership with increasing the program relevant and participant trust. And for the addressing the unique need, the community-driven strategy, as highlighted by WHO, effectively tackle especially challenging and improve health outcome. That you can see our graph here, the PrEP CBO and PrEP facility are a bit different that PrEP CBO are increasing all the time. If we compare with the PrEP facility. During our implementation, we also have some challenging. If we talk about the retention, our HIV self-testing and therapy to reduce client and drop its service. And for about the PrEP, and we hopeful that they gonna be and further reduce the pill taking and clinic visit. And if we look back on the community, we established the PrEP as a community standard driven by peer through social media, dating site and promotion and community gathering site. And we also challenge the cost barrier that make PrEP free at all costs and include client registration and access fee. And lab cost unit is established as a community standard with the demonstrable result. And we also challenge with some limitation, but our resources are limited resources are restricted, develop and making innovative and sustainable solution essential for our coming this challenge. That's all from my presentation, and this our team are involved. Thank you for your listening.
Thank you so much, Dr. Bora. That is really interesting and inspiring. I would love any governments to have that, like this very clear vision of how PrEP in the country will be introduced, will be rolled out, and how innovations can be added into that like roadmap of PrEP. So this is really wonderful. And I think now it is time for the Q&A session. I would like to ask Dr. Bora, Heather Marie, and Kincho to please turn on your video, and now we can start with the questions that we have had so far. Thank you, Kincho, and Heather Marie and Dr. Bora, can you please turn on your video? Thank you. Wonderful. So we have many questions around Len and Heather Marie. I think you can see it in the Q&A box already. And I don't know like which questions we should address first because there are those related to like the clinical information for Len, as well as the implementation questions on Len as well. So why don't we start with information around like approval by all those regulatory authorities at the global level, and also like the plan for countries in our region, especially that like someone mentioned that Malaysia would not benefit from the generic drug that we will gain through the voluntary licensing in 2027. So how are these things going on? Any global or regional efforts trying to address these things?
So there's a lot going on and a lot of conversations, and I'm sure other people as well on this call will be able to add additional information. To date, lenacapavir has only been approved by the EMA and by the US FDA. So there's 2 approvals. However, we know that approval, Gilead has submitted to South Africa, to Brazil, and is planning on submitting to a range of other countries, particularly the 9 early adopter countries that are being funded by Global Fund. So Global Fund is funding or subsidizing lenacapavir in 9 early adopter countries. Unfortunately for our region, those are all based in Africa. So 8 in Eastern and Southern Africa and 1 in Western and Central Africa. However, we also know that PEPFAR is interested in funding lenacapavir. And so we are hopeful that both Global Fund and PEPFAR will be considering countries within this region going forward, and certainly this is something that we're advocating for. In terms of the challenge with the licensing agreement, this is something that UNAIDS at a global level has been advocating, gosh, for most of this year, and definitely some of last year, to try to look at different options to overcome this. I don't have a solution to this at the moment. What I can say is that in the case of Brazil, which is also facing a very similar situation, that most of Latin America, or a number of countries in Latin America, were also excluded from the licensing agreements. And so they are doing direct negotiations with ViiV. There's lots of support out there, but it is still very early. And unfortunately, I have to admit, I am not a medicines access expert. So I'm more than happy to connect people with the right experts on medicines access on this. So please understand that I'm much more on the guidelines point of view. But this is definitely something that I think is really important. I firmly believe. And wonderful. I didn't know if it was public yet, Stephen, or Steve, but Steve has put in the chat that his understanding is that PEPFAR will support lenacapavir in the Philippines. So I had looked to see if there was any kind of announcement yet, but glad I wasn't the one if there was any confidentiality about this. So, and I also know that Global Fund has been speaking with countries. Global Fund teams have been speaking with countries about the possibility of including lenacapavir in GC8. So if this is something, if you are a Global Fund country that has an HIV grant, this is also an opportunity. So there are opportunities through the manufacturer, opportunities through Global Fund, and that's probably all I can say at the moment.
Mm-hmm. Mm-hmm. Wonderful, Heather Marie. I think these are all great news, and thank you, P. Steve, for sharing that information in the chat box as well. We do hope that we as many countries in our region should benefit from any potential support of LEN, either through Global Fund or through PEPFAR. And I think supporting countries where, as Dr. Bora just mentioned, community-led PrEP service delivery model are the key service delivery model for PrEP rollout in the country would be really useful, not only for PrEP to reach people, but also for us to learn how this injectable PrEP can be delivered through with community leadership. Right. So Dr. Bora, there are also a few questions related to what you mentioned about the tele PrEP or mobile PrEP, as well as the community-led PrEP services, in which you may want to share a bit more of how it is currently conducted, or how you have planned to conduct this or integrate this into the main PrEP service delivery system in Cambodia, and how it could be like become a national level tele PrEP or mobile PrEP service delivery, because in other countries it usually will be like a small demonstration project, but would not be taken up by the country.
Yeah, thank you, Dr. Nitya. Yes, for our country here, we worked for all years ago to have how to elaborate community and facility linked together, because these are support each other for the HIV patient experience, and up to now for the community can help to bring the people from the community to access the facility. And for the PrEP, we follow that our experience to bring the community to provide all information that PrEP need from the community, and we have set up the team that can come to bring the PrEP from the facility to the CBO and send them right to the community. Actually, we design like hub and satellite. Hub, I mean that the facility is a hub that can provide all the medicine to the satellite that we call CBO. So that CBO will work together with the community and provide distribution the PrEP to the community. And if we come back for the mobile PrEP or tele PrEP, actually in our plan, and we will get SIG approval from our Ministry of Health for this. Before that, we need to develop something, strategy and guidance or manual how to deal on that first. Now we are on the way to submit on this to MOA. In case that MOA will approve, we can conduct this. Maybe we hope that next year, because maybe in beginning of 2026 we can start mobile PrEP or tele PrEP. That we hope. Yeah. Thank you, Dr. Nitya.
Thank you so much. So for those of you who are interested in this like digital or technology based interventions to enhance HIV cascade, including HIV prevention, I think please be invited to join tomorrow's session that we will focus on this aspect as well. And I know we are a bit behind time, but please let me ask the last question to Kin Cho. You pointed out very clearly that there are a few countries in our region where we have seen like dramatic increase in new HIV infections as well as HIV related deaths. And I can see that these countries, when you look at the data on treatment coverage and prevention spending, they are very much correlated, right? So what would be your suggestion, your recommendation for like these particular countries, and how we as a region can help advocating for more funding or more initiatives to come to these countries?
Thank you, Dr. Nitya. So I think the question is more general. It's because we can't really pinpoint on one or the other. So I think I would say, because we can't really advocate just for prevention or pitting prevention against treatment, because everything is equally important. But usually when people become infected with HIV and become people living with HIV, it is easier to advocate with government, as this is the responsibility for the government to take care of the people living with HIV. That also explains a little bit about the higher commitment from the government to shoulder the HIV treatment costs rather than the prevention costs. But one thing we really need to keep reminding to the policymakers and all these relevant stakeholders is, if we can do it right on prevention, we can basically avert all these downstream treatment costs. So I would say that, because, for example, some countries, we already see the rising AIDS-related deaths, because this is going to the phase of failed tertiary prevention, right? So we fail at the primary prevention so that they get infections, and then we also fail to prevent the secondary prevention and getting to the tertiary prevention, and then we are seeing the rising AIDS-related deaths. And we can also see that rising AIDS-related deaths, for example, can be linked with the late diagnosis or late treatment initiation. And then the structural barriers, stigma barriers, they started the treatment and then lost the follow-up because of the multiple and various reasons, including the stigma, not doing the task shifting enough, so they are reluctant to go for the services. So that is the rising deaths trend. But the rising new infections is usually, we tend to focus only on the traditional approaches, and we are not emphasizing enough on giving choices and options for prevention. So like Heather Murray mentioned, it is not either or approach. It is not just this is that one thing that you have to follow. We have to give option and choices in the different phases of life, different age groups, different population, different educations. So we have to make sure that we follow that the principle of prevention, option and choices. And if we trust in the community that they can understand and deliver the services, then we can cohesively and comprehensively solve these issues of both rising new infections and the rising AIDS-related deaths.
That is a wonderful, beautiful answers from you, Kin Cho, and it brought us back to the first part of the open remarks by Nattapon regarding addressing stigma discrimination, about empowering people, about trust in community leadership, and I think that really a beautiful way to brings us to the end of this Q&A session. I know Heather Marie, Dr. Bora, and Kin Cho, they're trying hard to answer all those questions in the box, and please feel free to read through the answers, and also to visit the links that Heather Marie just provided in the chat box. So thank you so much, Kin Cho, Heather Marie, and Dr. Bora for this wonderful presentations and Q&A session. And now let me move to the next session, which will be moderated by Rina Chan Amnoy Suk, who is the Program Manager for Implementation Science at IHRI. Rina, can I give the mic to you now?
Yes, thank you very much, Dr. Nitya, for handing over, and it was a really wonderful session presented by the three speakers on long-acting PrEP and the HIV epidemic in our region. So now it's time for the community. So may I ask our community members to turn on your video? Can you hear me okay? Okay. All right, so yeah, good morning, good afternoon, everyone. So my name's Rina, as presented by Dr. Nitya. I'm from IHRI, based in Bangkok, Thailand. So welcome to our regional exchange on best practices and sustainability of the community-led responses to strengthen HIV prevention, care, and treatment in our region, Southeast Asia. Now, today we are very lucky to have with us today two incredible community leaders. From Thailand, we have Kun Siripong Sichua from Service Worker in Group Foundation, or SWING, one of the most respected organizations supporting sex workers and key populations in Thailand. And from the Philippines, we have Danvik Rosendino from Love Yourself, an organization that has completely transformed how HIV services are delivered through community-driven innovation and compassion. Thank you both for joining us today. All right, let's start off. So yeah, could you please each briefly introduce your organization and share with us how your work contributes to strengthening HIV prevention, care, and treatment in your country? Yeah, so maybe any one of you can start first.
Yes, I can start first.
Okay, sure.
Thank you, Katerina. Good afternoon and good morning, everyone. My name is Siripong Sichua, or ARM, and I'm currently serve as the Strategic Communication and Innovation Lead at SWING, or Service Worker in Groups Foundation. And yes, our foundation has worked for over 20 years, since 2004, as a bridge between marginalized community and Thailand public health system, focusing on sex workers, men who have sex with men, transgender people, and youth. We operate community-based clinic providing HIV testing, PrEP, PrEP, STI, and hepatitis C treatment. Our care team also provide follow-up and referral support for people living with HIV to ensure they are linked to treatment and care within the hospital system. And we apply the CLHS, or community-led health service approach, emphasize the friendliness that understand community lifestyle, challenges and need, making HIV testing feel like any other health service. Beyond service delivery, SWING advocate for right-based and stigma-free access, ensuring that national HIV response truly reach those most who are at risk.
Thank you for introducing SWING at the first part of this session. What about you, Danvik?
Yes, thank you, Rina, and thank you everyone for this opportunity. So I am from Love Yourself. Love Yourself is an organization that was established in 2011, and we are a community-based organization providing sexual health, including HIV, transgender health, and mental health services. And we provide these services, basically primary healthcare services, in community centers that are located in 15 locations all over the Philippines. And we are also providing technical support and capacity building to 50 other community-based organizations in the Philippines for them to become the next Love Yourself. And also, we are an organization that also conducts community-based research and other implementation science research to dictate evidence-based advocacy so that we could advocate better on how to improve the services that we offer, not only in our country, but in the world.
Yeah, thank you very much, Danvik, for introducing to us all about the Love Yourself. So now the next question will be like, both of your organizations have been true pioneers in community-led health services. So my question is, what makes the community-led responses uniquely powerful in reaching people most in need? Maybe let's start with Danvik.
I think it's very important to note that community-led work is always unique in one way or another. As we always say in the communities, we know the market because we are the market. We know the services that we will be offering, how we will offer it, how will we generate demand for it, how will we market it. Because we are the ones that are offering it, are members of those communities who wanted to access these services also. So we know, we understand ourselves, we know our stories, our challenges, and our realities, and how to respond to those challenges and realities. How can we improve how we offer primary care services in the community? How can we ensure that our spaces, when we establish our, where we offer our services, are safe spaces for the communities to access them? And how do we make it first client-centered, because we understand the different target markets that we want to reach. And also, how do we make it differentiated? Because we know that one size doesn't fit everyone. For example, a response for gay, bisexual, and other men who have sex with men will not work for transgender women and for other gender diverse individuals. So we have to diversify our efforts so that our goal is to reach each and every one that we want to reach, in the hopes that we offer a safe space for them to access services.
That's brilliant, Danvik. Thank you very much. And turning to you, any thoughts?
Yes. Yes, for swing our community-led model success, because like the trust come first. Our team come from the same background as our clients. Me too. I'm one of the sex worker. I'm the sex creator. Yeah, we understand the reality of nightlife, migration, and stigma. This allows Swing to engage people who might avoid formal clinic. Swing currently operate 3 branches across the Bangkok area and 1 in Pattaya, with a new branch planned soon to ensure service coverage throughout Bangkok. And additionally, Swing implement the one-stop service model under the RRTTPR. RR represent on-site and online outreach approach. T stand for testing, including both clinic-based and proactive mobile testing, as well as HIV test distribution. T also mean treatment under the community same-day ART model and referral to Thailand National Treatment System. P stand for prevention, combining information, condom, PrEP, and PEP, and R stand for retention, providing follow-up support and regular testing encouragement. We combine peer outreach, real-time counseling, and flexible service hour with scientific protocol and data system. This balance of community empathy plus medical quality make community-led service in Swing both effective and sustainable.
Yes, thank you for that. And maybe I have another follow-up question, as Swing has been such a key part of Thailand's HIV response, especially among sex workers. What are some of the most effective community-driven strategies that Swing has actually used to engage people who might otherwise be missed by the mainstream healthcare systems?
We use peer-to-peer outreach, nightlife engagement, and digital platform for anonymous booking and online counseling, mobile testing and same-day PrEP and ART initiation make access immediate. So we also integrate mental health screening using verbal counseling approach and gender-affirming care, addressing holistic well-being, not just HIV prevention. This approach allows people who would distrust government hospital or fear exposure to access service safely and with dignity.
And I think thank you, and from the previous presentations around long-acting PrEP, I would like to learn more about how Swing contributes to integrating community-led services like HIV testing and PrEP into Thailand's national system and policy frameworks.
May I have the question again, Purina?
Yes, I would like to know about how Swing contribute to integrating community-led services like HIV testing or PrEP into Thailand's national systems and policy frameworks.
Swing was one of the first CBO accredited under Thailand community-led health service model. We pilot PrEP delivery and HIV testing by trained community provider. Collect data that demonstrates safely and efficacy, and share results with the Ministry of Public Health. Through national advocacy with our network like IHRI or APCOM, we help ensure community clinics are now officially reimbursed under Thailand Universal Coverage Scheme, milestone for sustainability and recognition of community capacity.
Yes, and thank you. And just a small note to our audience, if you have any questions to our 2 guest speakers, feel free to put your questions in the chat box. And then after this session, we will have a few minutes to go through your question. I will ask each speaker to respond to your questions accordingly. All right. Yes. So now turning to you, Danvik, we all know that we are not doing good enough for young people in our region. So Love Yourself has really led the way in using innovation to expand HIV services in the Philippines. What approaches have proven most effective in engaging young people and other young key populations?
Thank you for the question. I think the opportunity is there to make us understand what the youth really wants. I think the real beauty of introducing client-centered and differentiated health services is letting our clients themselves design and be the architects of their own service, because they know what they want and they know how will they create that service. Because if they were able to establish that, we know for a fact that they are themselves will access it. So I guess what we did in our organization is that we have provided the youth members of our community to provide insights and to create hackathon sessions with them, or we call it client-centered designing sessions with them, so that we were able to provide to create the perfect package on how we would package it to the youth or to the clients who need them the most. And in Love Yourself, from those hackathon sessions, we knew that that our services needs to be in these 3 pillars. The first one, definitely it should be client-centered. The second one, it should be pleasure integrated. And I think the most important one is we need to have evocative messaging in our services. Evocative messaging meaning it evokes emotions, or we let our clients decide what is the best for their lifestyle, as opposed to directive messaging, where we say to our clients, you use PrEP, oh, you should go for treatment, oh, you need to go for HIV testing because you are at risk. So if we go for that directive messaging approach, our clients tend to say that they don't have the tendency to follow them, because that will not be adaptable and palatable to their lifestyle. So I think evoking evocative messages makes them understand and think for themselves how will they create and decide what's best for them and what works for them. So that's I think that's one strategy that we gathered from the young key people, so that we were able to adjust our current innovations and services we offer and adapt it to the young people.
Yes, thank you. That's amazing answer, Danvik. And so I understand that both of you work in a very different environments and settings, and I think it's similar to every one of us who are attending this session, now that we are representing different countries of origin. So I would like to know more from both of you that what do you think that we can learn from each other's experience? How can countries in our region better share lessons and strengthen community-led HIV response together? Maybe Arm?
And then we go first for this.
Okay, sure.
Okay. I think we need to understand that in the line of work that we do, even though we are trying to put our best efforts and the communities have, all of these insights to make our services better, we know for a fact that the communities cannot do it alone. And I think it's important for us to seek support from other people who are willing to partner with us, to join us in order to bring these services, make them accessible to the communities, and how we make it sustainable. There are so many ways where we could learn from each other, but I think what I also understand that different stakeholders have their different strengths, have their different capabilities, and have their different realities. And if we are very much willing to share these stories, share these realities to each and everyone, I think we are able to create an HIV response that is sustainable in itself. It's accessible for everyone, and understanding best practices and adapting it to each to our practice we will be able not only to learn from each other, but learn from what we are doing and what we are offering so that we could improve how we offer our services. I think that's one way where we could, really work together so that we improve the way we offer services for the communities.
Yes, thank you. Any reaction from you,
Yes. For me, I believe that we can strengthen community-led model by sharing evidence, experiences, and trust across the country. Each community has different realities, but we all share the same goal, right? To make service reachable, respectable, and relevant. At Swing, we have learned that collaboration works best when community, government, and scientists learn from each other as equals, not in top-down way. We need more regional learning space where community providers can exchange practical tools, training, and data, and where policymakers and donors listen to what actually works on the ground. Together, we can build a regional network of community-led health system rooted in science but driven by compassion, so no one is left behind.
Right. Okay. I was asked by the organizer to finish off this session, but I would like to finish with one last question around sustainability. I know that this is something that we all worry about as donor priorities and funding sources shift. How have your organizations managed to keep programs running and maintain community trust even when resources are limited or changing? And what kind of partnerships have been most effective in keeping your services sustainable and expanding? Yeah, Danvik.
I think for us to ensure to keep our organization running is we need to know for a fact that we cannot give ourselves to others if we don't have a self to give. So for us to establish that resources for us to give back to others, we need to first ensure diversification in our sources of funding, where we established social enterprise to offer other services other than sexual health, other than transgender health and mental health services, where we have private models now where we in our organization we call them Lux Care. More than concierge medicine, we also offer aesthetic medicine. But we also enabled other private partnerships with other corporate partners so that we could activate advocacy and philanthropy. And I think we also use the power of influencers so that they could influence the response. Like, for example, we did a project with Pia Wurtzbach, our Miss Universe 2015 here in the Philippines, so that we could activate advocacy and philanthropy so that we could raise funds to establish youth hubs and other projects that are targeting the youth. So it's really more of really activating any possible resource that we have so that we could, pool those resources and give that maximum effort to the communities who need our services the most.
Well, that's a very innovative implementation strategies from the Love Yourself. Thank you so much, Danvik. What about you, Any reactions?
Yes. At Swing, we diversify resources. We're combining government reimbursement from Universal Coverage Scheme and from National Health Security Office. We have the private clinic income and social enterprise initiative, like training programs, events, and creative campaigns to reduce reliance on external donors. Internally, we invest in staff development and data system to strengthen accountability and attract new partner. Yes, that's what we do. Even we open our small restaurant, sell papaya salad and steamed rice, chicken. Yes, in Pattaya, right?
Wow, that's very interesting. And I had an opportunity to try your chicken rice already in Pattaya.
Yeah.
It's really delicious. Yeah, thank you. Thank you so much. All right, now I think we have come to the end of the session by opening the floor for our participants, audience, to ask you both questions. So maybe we have a few questions raised by the chat box already. Okay, that's one of the questions I'm directing to Danvik. Danvik, could you please share the strategies to engage with hidden young key population in your areas? Which KP-friendly services should we apply to get more contact with the young groups? Thank you.
Yes, that's a very good question. And I think the beauty, as I mentioned, the beauty of creating differentiated services is that the offering of the package that we offer the service doesn't change. We still offer testing, we still offer prep, we still offer access to treatment. But how we offer it, it's different for each and every population. Like, for example, if we promote our services online, then we create online marketing strategies and campaigns so that we could reach a maximum number of people. And, directly advertising it to the people who need them the most based on their profile. But offline strategies are also very effective. Like, for example, offering it to organized groups or other communities who can reach out to other clients based on their lifestyle, based on their location. I think it's really important to understand first, where are we offering the service? To who are we offering the service? So that we could adjust how we offer the package to the clients who need them the most. So I think it differs to each location, each country, each reality, each story. It really differs, and we have to understand those stories at first.
Yeah, that's a very brilliant answer. Yeah, one strategy may not work for may work for a group of population, but might not work for another group of population. So this is very interesting. All right, now I think this question goes to you. Where can migrant workers in Thailand who are MSM get healthcare services, and are these services provided for free or paid?
For this question, in our clinic at Swing, in all our branches, give the service free for migrant, that is Myanmar, Cambodian, Laos. Yes. Yes, we will give them for free service.
And it's including HIV testing and
yes,
PrEP as
everything,
well?
PrEP and HIV testing.
Yeah,
Yeah,
okay.
they have the same right as the Thai people that have the free testing like 2 times a year.
Okay, right. Thank you. And maybe it's the question and actually comes from myself based on the previous presentation on long-acting PrEP, including Cap-LA and LAN, or even other investigational drugs in the pipeline. Do you think that what are the roles of the community in promoting long-acting PrEP in your settings? Yeah, maybe in the Philippines or in Thailand, or what should be done, from the community side to promote or to increase access to long-acting PrEP? Starting with you, Danvik, what works for you, right? I saw you wearing a very lovely t-shirt.
Yes, I think it's important to understand first that these options are not, as mentioned by Heather Marie, it's not meant to replace one option. We should offer all of the options for the communities and let them define what works for you. And I think it's really important, more than the promotion of these options, I think the communities can also stand and be architects of offering the service in itself, because we know how to reach to the communities. We know how to customize and perfect the package so that we could offer it to the more communities who need them the most. And I think here in the Philippines, we have proven it as an organization where we introduced the offering of oral PrEP here in the Philippines. And I think we are also in the way of supporting any introduction efforts to offer long-acting injectables. And we are very happy to work with them, not only in demand generation, but also service acceleration. And service acceleration includes offering it under an implementation science research, because we always learn along the way. So very important to offer it, and we learn based on how we offer the service to the clients who need them the most.
Yes, thank you. Thank you so much, Danvik. What about you,
Yes. For me, it's familiar, like Danvik said, but yeah, the community our Swing plays a role as like the critical bridge role in expanding access to long-acting PrEP. Like first, community like Swing are essential to creating awareness and demand, explaining to client what long-acting PrEP is, how it works, and addressing fear or misconception about injection. Peer educator and online platform help translate complex science into friendly and real-life language that people trust. And second, we act as a connector between client and the health system. Community clinic can pre-screen, provide counseling, and refer client for long-acting PrEP initiation at hospital or research site. This makes the process smoother and less intimidating. And third, community data and feedback help policymaker and donor understand who is ready and what access barrier exists. Whether cost, supply, or consent procedure, that information is vital for designing equitable rollout strategy. And finally, through community-led demonstration project, we can pilot real-world delivery model, for example, combining long-acting PrEP with STI or hormone service to prove feasibility before national scale-up. Yes, and that's from me.
Right. Thank you. Thank you. So thank you so much, Danvik and for sharing such thoughtful insight. It's really inspiring to hear how both Swing and Love Yourself continue to lead by example. And thank you very much to everyone for joining us today. So before I hand the microphone to Dr. Nitya, I hope this conversation sparks more collaboration across Southeast Asia and as we continue working together towards an HIV-free region. So thank you very much for attending and for listening. Over to Dr. Nitya.
Thank you so much, Reina and Kun and Danvik. It's so nice to see you, both of you here, and thank you for joining the webinar. So I think we have come to the end of the session today, and I would like to just do a quick wrap up of what we have learned for today. And I think we have a great list of speakers and panelists from Kincho, from Heta Marie, from Dr. Bora, and then Rina, a great facilitator, Kun and Danvik, for the session today. And I feel that we have been reminded of the urgency of the work that we still need to continue even with the challenging funding landscape in our region, because we have seen a dramatic increase in new infections, in deaths in certain countries, and I don't think the situation is getting better in many other countries as well. We also have learned that the new innovation has potential to really come to our region, and that we need a stronger and concerted efforts in trying to bring it sooner to the region and make implementation science or implementation real in our region. And I hope that at least Cambodia, Philippines will lead the way in our region. And then we also learn about the power of community leadership from and Danvik, that with the leadership, it's not only community bringing services to the people who need it most, but also the findings, the experiences, the science and the stories of what we have been doing can also be as powerful as science from researchers to change policy, or even stronger than science from researchers to really change the policy for health equity. And lastly, I think that we are all encouraged by seeing that community leadership, community-led activities are still ongoing, are still very active in our region, and that we will learn more of the evocative messages, palatable messages that Danvik mentioned. I think that's really key on how we continue to generate demand, not only for PrEP, demand for HIV testing, demand for treatment, demand for people to retain in HIV treatment or HIV prevention programs. And with that, I would like to thank all the speakers, the panelists again, and also to thank everyone who joined us among the audience. And tomorrow we will continue the virtual symposium discussing mainly around chemsex and virtual interventions or virtual solutions.